Hi, this is Dr. ROJoson, Director of ROJoson PEP TALK. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. I launched this PEP Talk on May 15, 2021, with the first module on COVID-19. The second module was on patient empowerment. I am now on my third module entitled Patient Management Process. What I had in mind in my PEP talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. That is my key performance indicator. I hope you will be in my group of 30. This is the patient management process framework. In this module on patient management process, there are 6 parts, namely overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process, peculiarities and limitations of medical practice. For today, we'll be talking about the clinical diagnostic process. So my PEP talk today will focus on this part of the patient management process, goals, and the clinical diagnostic process. The title will be Patient Management Process, Clinical Diagnostic Process, and the empowerment objective will be for the lay people to have an understanding of the goals and clinical diagnostic process in the patient management process. The patient management process starts with a patient consulting a physician for health concerns. There are 2 categories of reasons for medical consultation. One is consulting for management of a symptom or set of symptoms. The other is consulting for screening for a disease or diseases. Although the PMP is applicable to both categories of medical consultation, I will focus on the management of a patient with a health problem so that I can easily give scenarios or examples for illustrative purpose, scenarios that you are quite familiar with. A patient consults a physician. The goals of the physician are resolution of the health problem in such a way that the patient does not end up dead, as much as possible with no complications and no disability, and in such a manner that the patient is satisfied. These are the universal goals of all physicians, and these are also rightfully the expectations of the patients. There are caveats in these goal statements. Medicine is an inexact science with nothing absolute, nothing guaranteed, with no perfect achievement of goals all the time. Despite these harsh realities, an idealistic goal should be set to guide the physicians, their fighting target. What is most important is that physicians exert their best, rational, honest, and humane or compassionate efforts in managing patients to the satisfaction or delight of the patients and relatives, even in the absence of complete resolution of the health problem. As mentioned earlier, these goals of the physicians are rightfully the expectation of the patients, but the latter, meaning the patient, should understand the limitation of medicine and also their physicians when the goals are not completely achieved. They should appreciate the physicians as long as they exert best, rational, honest, and humane or compassionate efforts in caring for them. To achieve the goals, a physician performs 4 basic categories of functions or tasks. These are rapport, diagnosis advice, treatment advice, and advise. The general quality standards that can be used for these four tasks are rational, effective, efficient, and humane. After establishing rapport with the patient, the physician starts accomplishing the task of diagnosis. Diagnosis means coming out with a statement of what a patient has at the current moment after evaluating the symptoms and signs. If the patient comes in with reports from the laboratory examinations and procedures done prior to consult, they are included in the evaluation. Before coming out with a diagnosis, the physician interviews and does physical examination on the patient. The data gotten from the interview are called symptoms, meaning what the patient feels and observes in and on his body, which can be a manifestation of a medical condition or disease. And the data gotten from the physical examination are called signs, defined as findings obtained by a physician after doing a physical examination. A diagnosis just derived from symptoms and signs is called a clinical diagnosis. In some instances, a patient consults a physician bringing along reports of diagnostic procedures done earlier. In such instances, the physician will incorporate the data from the diagnostic reports in the clinical diagnosis. In processing the symptom and sign data and other data for that matter, the physician uses the clinical diagnostic processes called pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of disease. Pattern recognition is essentially the same as a matching process. Prevalence process means choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. Illustration 1 of the clinical diagnostic process, knowing the common manifestations of 5 different diseases as follows. This is A, B, C, D manifestation. This is B, F, G, H, I. This is C, K, L, M, N. This is D, P, Q, R, S. And this is E, U, V, W, X. Given the patient manifesting with PQRS, your diagnosis is disease D. What is the process used? Pattern recognition. Illustration 2, knowing the common manifestations of 3 different diseases and relative frequency of each as follows. This is A, B, C, D manifestations, but the least common. This is B, A, B, C, D in between in terms of frequency. This is C, A, B, C, D, but the most common. Given the patient manifesting with A, B, C, D, your diagnosis is disease C. What is and are the processes used? Pattern recognition, but mainly prevalence. Illustration 3, knowing the most common diagnosis of a thyroid nodule is a benign colloid adenomatous goiter. So given the patient with a thyroid nodule, you gave the aforementioned diagnosis. What is or are the processes used? Prevalence. Patients presenting with these pictures of mouth defects, who has the cleft lip for a diagnosis, and who has the cleft lip and palate? What is the process used? The one on the left side of the screen has cleft lip because only the lip is involved. The one on the right side has cleft lip and palate because the palate is also affected. The process used is pattern recognition. The patient has bulging eyes and enlarged thyroid. What is the diagnosis and what process is used? Bulging eyes and an enlarged thyroid gland are the usual presenting signs of hyperthyroidism. We recognize a pattern for hyperthyroidism. Thus, the diagnosis is hyperthyroidism, and the process used is pattern recognition. The patient has cough, colds, fever, and tiredness. COVID-19, flu, and common colds present with the same set of symptoms. So how does one process for a diagnosis? COVID-19 should be the primary diagnosis during time of COVID-19 pandemic. The process used is prevalence. During time of flu, pandemic, epidemic, and outbreak, when COVID-19 and common colds are not common, then flu should be the primary diagnosis. The process used here is prevalence. At this point, I'd like to insert something still related to our discussion on the clinical diagnostic process, but which I advise you to remember for the rest of your life and be empowered by knowing, for chances are you will be confronted with it now and in the future on yourself and on your loved ones. How to diagnose a mass on the body surface using pattern recognition. Foremost question to ask is the body surface mass cancer or not cancer? Using pattern recognition, know and then look for signs of cancer and also signs of not cancer. If signs of cancer are present, the primary diagnosis is cancer. If no cancer signs are present, more likely not cancer, especially if there are signs of not cancer. Signs of cancer that can be used for pattern recognition are hard solid mass, fixed, skin changes, presence of lymph nodes, distant mass suggestive of a spread. On the other hand, signs of not cancer that can be used for pattern recognition, cystic mass, signs of inflammation and infection such as pus, redness, and tenderness, etc. The output of the clinical diagnostic processes is a diagnosis. As mentioned, a diagnosis is an identification label of the patient's health problem. The elemental steps in making a diagnosis or a diagnostic statement consist of the following. Identify which organ or tissue or system is involved, then identify the disease in general terms such as inflammation, infection, tumor, trauma, endocrine, etc. And then try to be more specific in identifying the disease, if possible, such as malignant neoplasm, abscess, etc. Examples of diagnostic statements: right breast mass, malignant. So right breast represent the organ, tissue, or system. The mass, the disease in general, and then malignant is the specific disease. The same goes for the left thyroid lobe mass, malignant, and skin lesion trauma, lacerations. Knowing the nomenclature of diseases facilitates diagnostic labeling. Note, however, the diagnostic labeling does not always have to contain the name of a disease. The patient may not have a disease after all, or may just have a medical condition that is not equivalent to a disease. In such situations, the diagnosis may contain statements like essentially normal findings, normal anatomical variation, medical condition, state the symptom, example, headache or pain, that will most likely resolve spontaneously in due time. Since medicine is an inexact science with nothing absolute, there's usually no such thing as one absolutely certain diagnosis after an evaluation. This is there is usually an alternate diagnosis. Thus, in the end, the outputs of the clinical diagnostic processes are at least two diagnoses: the primary clinical diagnosis, which is the most probable or most likely, and then the secondary clinical diagnosis, which is the alternate or the second most probable or the less likely diagnosis. With the harsh reality and limitation of medicine, a diagnosis is almost always an educated guess. Note the adjective for the guess, which is educated. It has to be educated to be acceptable in the medical profession and to the lay people and patients as well. And to come out with an educated guess, a process or processes should be used. The clinical diagnostic processes must be rational for the clinical diagnosis to be acceptable. There is an adage that states, a diagnosis that is based on a rational process is not always correct. However, a diagnosis is more often correct than wrong if it is rationally arrived at. Going back to the primary and secondary clinical diagnosis, the physician must quantitate his degree of uncertainty or certainty, as this will serve as a guide in deciding whether a paraclinical diagnostic procedure will be needed or not. As a rule, if the primary clinical diagnosis is certain already, no need. If it is not certain, then there is a need for a paraclinical diagnostic procedure. How to quantitate? At the moment, there is no universal agreement on this. I will just share with you my practice, which I find practical in the determination and in explaining to patients. Use two dichotomous terms, certain and not certain. At times, for very certain, not certain, certain, very certain. This is for the sake of the patient's better understanding. Use a subjective probability percentage for cutoff in the dichotomy, 90%. So certain for 90% probability and above, not certain for less than 90% probability. The subjective probability percentages can be given as 60 to 40%, 70 to 30%, 80 to 20, 90 to 10, 95 to 5, 98 to 2, and 99 to 1. The first percentage is for the primary clinical diagnosis, and the second percentage is for the secondary clinical diagnosis. Thus, the range of the uncertainty is from 60 to below 90, and the range for certainty is from 90 to 99%. Examples, 99 to 1% means 99 probability for the primary clinical diagnosis and 1% for the secondary clinical diagnosis. 60 to 40 means 60% probability for the primary clinical diagnosis and 40% for the secondary clinical diagnosis. If there are published frequential probability statistics in the literature, use them but place them in either of the two categories of certain and not certain. Use the relative strength of the symptoms and signs and the processes used. A clinical diagnosis is considered to be certain if it is based primarily on signs supported by symptoms and prevalence data. A clinical diagnosis is considered to be uncertain if it is based primarily on symptoms or on just prevalence data. Notes. Signs. These are the data gotten by the physician after examining the patients. These are usually more reliable than symptoms, which are the data gotten from the patients, their feelings, and observation. And note number 2, the diagnosis based on pattern recognition supported by prevalence is more reliable than that based on prevalence alone. Examples of diagnostic statements with quantification of probability percentage. Patient 1, primary clinical diagnosis, right breast mass, malignant, 99%. Secondary clinical diagnosis will be 1% for non-malignant. And then patient 2, primary clinical diagnosis, right breast mass, malignant, 80%. And secondary clinical diagnosis, right breast mass, non-malignant, 20%. After the clinical diagnostic processes and formulation of clinical diagnosis, the physician gives advice to the patient, meaning he gives and explains the findings and diagnoses and entertains and answers questions from the patient. The clinical diagnostic process and the patient management process ends at this advice box. So we stop here for the moment, for today. Takeaway in this PEP talk that are related to the patient management. At this point of the PEP talk, up to the clinical diagnostic process, understand the patient management process framework in terms of what the physicians are doing and should be doing in the goal setting and in the clinical diagnostic processes. Be ready to ask questions based on the requirements of the processes, particularly when a physician is not using the processes and is not clear and full in explanations. Participate actively and fully in the problem solving and decision making of your health concerns with your physicians in coming out with a clinical diagnosis. Master the clinical diagnostic processes as they may help you in some way in doing self-diagnosis of your symptoms in the absence of healthcare professionals. This is another way of gaining greater control in your health concerns and issues. So with that, I end my PEP talk. Patient management process, clinical diagnostic process. I hope I have empowered you to have a better understanding of the goals and clinical diagnostic process and the patient management process. So with that, I'd like to thank you for your kind attention. Mabuhay kayong lahat.